This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. We're delighted that you're with us today. And you know, Thomas, kind of start to show the human side of healthcare with a very heavy human heart. As everyone knows, we lost two of our heroic healthcare workers at Methodist Dallas last week in a senseless, tragic shooting. And we want to remember those two individuals who have given of their time and energy to help others. And at the same time, remember that our workforce is really the human force that treats our patients every day in all our hospitals. And let's don't forget that as we begin this show.
Yeah, I echo those sentiments with you and certainly send my condolences and compassion being part of this from a production standpoint. But let me ask you this. The one in Tulsa several months back really hit home to me because I used to manage clinics. So is this isolated, or are we just, now we've got two that are very prominent. Do we have a trend?
Oh, we definitely have a trend, Thomas, and unfortunately it's nationwide. Violence in hospitals has always been an issue. Hospitals have always taken precautions. They've had protocols in place, but they have a delicate balance. They have to be open so family and friends can visit their loved ones in the hospital, but at the same time, keep the environment safe for the patients, the families, and the workers. And that's a hard balancing act. And unfortunately, the COVID-19 pandemic escalated the violence because, as you know, we had to restrict visitation, etc. People get angry. People act out. So unfortunately, this is a trend.
I know it's too early and we're not here to parse out things that people way above our pay grades are going to be making decisions on. However, I am very happy to see that law enforcement examined itself when the chief of police said that this was a failure of the judicial system. And my first question that I even posed to you when we started talking was, who was responsible for that ankle brace?
Yeah, that's a very important question, Thomas. And, Monday morning quarterbacking, we can learn. But I hope that with all these incidences, and we can put Uvalde in it also in a school system, I hope we can learn we need to prevent further loss of life. And I will tell you something else, Thomas. There is a pending bill in Congress, the U.S. Congress. It's been introduced in the House. We're waiting for it to be introduced in the Senate that would make it a federal offense to attack or have any violence against a healthcare worker, similar to flight attendants or flight crews. Congress needs to act on that immediately. Don't debate it. Don't spend a lot of time talking about it. Pass the bill.
And with that, let's take just a couple of seconds of silence to remember these two fallen healthcare workers and their families. May their loved ones be comforted, and may they rest in peace. Amen.
And now we're going to pivot, Thomas, and we're going to be talking about something very positive, about something that's going on at the JPS Health Network, where JPS has launched a child and adolescent psychiatric fellowship program. And we're delighted that we've got Dr. Alan Podawiltz with us today, who is the chair of psychiatry at JPS Health Network. Welcome to the show.
Thank you, Steve.
Before we even begin this discussion, so that our listeners fully comprehend, can you explain what is a fellowship program for physicians?
Absolutely. I think that sometimes people know that going to medical school and residency is a long haul, but let me kind of put this into some perspective that, many people have gone to high school. Then after high school, they go to college for 4 years. and then they go to medical school for 4 years after that college. And then once they're done with medical school, they go to a residency program. Some residency programs are 3, 4, 5, or even 6 years long. In psychiatry, it is a 4-year residency. So they have had now 8 years of medical training, medical school plus residency. Within a residency, you can then begin to specialize further, which means you're going to go into another whole area of study to increase skills in a particular population or a particular disease. And for psychiatry, the Child Fellowship is just one of those. It's 2 more additional years past the general residency that is completely dedicated to treating children and adolescents.
You know, you bring up such good points. And as I listened to your answer, I thought of a friend of mine whose 10-year-old daughter was beginning to withdraw, had a couple of acts of attempted self-harm, and they called, and it was going to be 90 days before anyone could see them. Is that common in this area?
It's actually common across the U.S., I hate to say. There aren't enough child and adolescent training programs, even though that we have residents who are dedicated to child and adolescent. Here at JPS, we've had at least 1 to 2 residents out of every year for the last probably 12 years go to another child and adolescent program in another state or in another city, which means that we've been growing the talent for child and adolescent here, and they've gone to someplace else to train, and once they train there, they tend to stay there. So this long wait is because of the small resource that we have with this particular profession. As we begin to build child and adolescent services, we need to have child and adolescent psychiatrists. And so as we take a look at now how to build more community services, for just like for that friend of yours, that we should be able to have that person be seen more quickly.
You know, I was talking to a board-certified child and adolescent psychiatrist the other day from another state, as a matter of fact, and she told me that she felt like attempted child and adolescent suicides were epidemic in this country. Would you agree with that statement?
Absolutely. The number 2 reason for death in children between 10 and 18 is suicide. It is a epidemic nature. Children at that level are always impressionable by peers, and what we find is that if there is a student in school that commits suicide, we expect that there will be other children in that school who will begin having those same thoughts, especially if they're thinking that they may be helpless or hopeless in their situation and they have depression, that suicide for children seems to be an option that they don't really think through fully, and so they may impulsively do something to harm themselves. But it is. Suicide in the children and adolescent is epidemic in this country.
Such a sobering thought, and why this new program from JPS is so important for us in North Texas. More from Dr. Alan Podawiltz, the chair of the Psychiatry Department at JPS Health Network. And the interview is on our podcast, The Human Side of Healthcare, also our YouTube channel by the same name. More on helping our kids navigate these times next on The Human Side of Healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're going to jump right back into this important conversation about the new Child and Adolescent Psychiatry Fellowship at JPS Health Network. This is Dr. Alan Podawiltz. He's the chair of the Psychiatry Department at JPS.
How are the mental health needs for a child or an adolescent different than the mental health needs of an adult?
I first have to go to family and probably the social systems in which the children are engaged. That one is being able to recognize at this age the symptoms that they may be seeing in some of their students, especially in schools. That beginning to withdraw, not really working, doing their homework well, not sleeping well, becoming irritable, being argumentative, those are maybe signs that the person may be experiencing a depressive disorder. And so with that, then in depression, the end result is that they feel like they get to this deep, dark hole that they can't see any light in, and then they opt for hurting themselves. So part of it is being able to recognize that dark hole. And that does happen to adults, but adults have a different kind of social network in terms of who they work with, who they may have better relations with communicating with their family. And adolescents sometimes, just because of where they are in terms of their growth, may not always trust talking to an adult. They may talk to a peer. And in children and adolescents can tend to be bullied more than people who are adults and working in adult life. And being bullied is one of those things that can really tip a young person over, thinking that they are not socially adept.
You know, you mentioned bullying, and I can only think bullying today through social media is 24/7. You know, when I went to school, you'd get bullied by the high school bully, but when the bell rang at 3 o'clock to leave, you didn't have to worry about it until the next day. Is social media really impacting the mental health of our children?
Ooh, that's a big question, Steve. Social media tends to really influence how people think about their lives and the world around them. And it doesn't just happen with children and adolescents. As you know, it happens with adults as well. But the difficulty is that when the adolescents or the children use social media to communicate emotions or behaviors, that they don't have the mentoring that a family member, a parent, a teacher may provide to that individual to help them sort through that bullying. I, like you, who years ago, the bully was at the school and you'd get on the bus and go home and not worry about the bully till the next day. And the ability to have that 24-hour bully right there on you, and it's easy to do, and people tend to think it's fad-like. So social media does have some play in how students have their emotions be more well-balanced in terms of what they do. They tend to trust the social media more than they do family. So part of it is that if families have difficulties with bullying, is to really begin to refocus the child back on family values with communication back at home.
You know, you mentioned that this program at JPS for Child and Adolescent Psychiatry, as far as the fellowship, would be 2 years. Can you explain a little bit about what does that 2-year training include?
When we study psychiatry, we have a generalist view of epidemiology, meaning how much illness is there, you know, what kinds of illnesses present at what times. And so the child and adolescent really takes a look at the children, the ages of 2 to 18, to really take a look at how are these illnesses, one, being manifested, because they can look a little bit different. A depression, an anxiety, bipolar, or even schizophrenia can look a little bit different in those populations. So they learn how to recognize those illnesses quicker and then learn how to treat them more effectively at that age. The other component is really looking at how to interface with families and family dynamics in terms of working with a person who's an adult with their loved one or their spouse is a lot different than working with a child and their parents. Oftentimes, the parents may have their own belief patterns, or they may have their own training that they went through. They may rely on their experience more than they do on what may be right. And so really being able to work with the family to understand what this illness is in the present time, that they're not making these assumptions about what they think it is, or that how my dad just said, pull yourself up by the bootstraps, you're going to get over this. That to really sit back and say, this child is experiencing something that is not normal for them, and how do we work them through?
So it sounds like, is there some classroom and some actual in the counseling room and engaged with the patients?
Oh, yeah. Let me see. I can do a typical day because no day is going to really look exactly alike. But what I can do is probably the week. So they'll most likely have a week of outpatient where they'll see adolescents, children and adolescents, in a clinic, in a clinical setting. They may spend a half a day in a psych hospital working with hospitalized students. Then they'll have an entire day, approximately 8 hours of didactic in-classroom training. Then they'll also have some time where they'll work with doing psychotherapy, 1 with the children, and 2 family therapy. So their day may have different kinds of activities that they'll be participating in throughout the entire week.
When somebody is thinking about going into child and adolescent counseling versus adult counseling, what are some of the distinctions that you would analyze for yourself that would lead you down the path of going into child and adolescent versus adult?
It's interesting. Over my 20 years here at John Peter Smith in the residency program that we've had, in really looking at the residents who decided to go on to either forensic or consultative fellowships and the child fellowships. The child fellowships, it tends to be the individuals who go into that really are interested in that child population, in that developmental period. They come to believe that if they can make an impact in that early time period, that they can change the course of an illness, which is true. And so many of them say, I want to start earlier than trying to capture them once they've already established a disease process.
Wow, that's a great point. You and Steve mentioned telemedicine. So is a student today training for this profession facing more of a telemedicine career than an in-person career?
Oh, well, there are options for people to go completely telemedicine. And one of the things that I'm beginning to see is that people who went primarily with telemedicine are missing the socialization, the camaraderie of being part of a team. And some of them are looking to see how can I balance that back out, having some real face-to-face time with patients. Sitting at a computer all day long doing this work can sometimes initially seem very easy, very nice. You're at home. But after a while, they tend to say, I need to be back with some peers. So there's that balance in between peer and the patient. The other is that, this is psychiatry. And even though we may have a good camera, the patient may be using their cell phone. So we don't always have a good look at all of the nonverbal cues that the patient is providing us. And those nonverbal cues could be from a foot tapping on the floor. It could be from them fidgeting with their hands. It could be them sitting very stiffly, which on a cell phone, it's difficult to capture that. So sometimes you can talk to a patient and go, hey, I have this general impression, but I can't get the whole story because I'm not seeing the human being. So there's a play between how many services can we get out there. Telehealth, definitely we can get services out there. But then are we able to really diagnose and engage with that patient? There's been some studies that say that the engagement is similar to live, face-to-face, and the telehealth. But then patients kind of go back and forth. What we found is that we were total telehealth in March, April, May, and June of 2022. And we've had that option available for patients ever since then. But right now, 80%, 75% of our patients are opting for face-to-face. 25% are opting for the telehealth.
Now, that's very interesting. Mm-hmm. So when you're in crisis, don't put me on TV. I want a couch and some Kleenex and a person.
Yeah, I wish we had couches still. but no, you're absolutely right. There's a level of empathy that occurs when a person leans forward when another person is emotionally distraught. To be able to reach across the table and just show an open hand. And that's difficult to do when you're on video. And so it's balancing that. We teach our residents how to do both. That if a patient can't make a live visit, that we will do it by televideo, just because we want to make sure that the patient is cared for and over time.
We'd like to thank JPS Health Network for bringing this important program to North Texas to help train physicians who will be taking care of our next generation of kids. We've been talking to Dr. Alan Podawiltz, the chair of the JPS Psychiatry Department. Now, when we come back, we're going to tackle a disease that 80% of us are likely to get that can result in cancer, but there is a preventive treatment for it. Find out all about it next on The Human Side of Healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. Delighted you're with us today. And you know, Thomas, no matter what vaccine you talk about, it could be COVID, it could even be childhood immunizations, even the flu shot. There are people that take it as, hey, we really need to do this. There are people that are a little hesitant. They step back. You know, two sides to every story. But there is something that we felt was extremely important to talk about, and that was the HPV vaccine. And all I can say is, especially if you have children, talk to your medical professional. But we thought it was so important that we hear from Dr. Jason Terk, who's a pediatrician at Cook Children's Hospital, to give us his insight, his thoughts, and his guidance related to the HPV vaccine. But again, talk to your trusted medical healthcare provider. Dr. Terk, welcome to the program.
I'm very glad to be with you today.
So, Dr. Terk, let's start at the beginning. What is HPV?
Human papillomavirus is a virus which is very easily transmitted from person to person. All of us are probably familiar with some types of HPV that we may have had with warts that we've had on our hands or our feet. There are lots of different serotypes or types of HPV, and some of those types are associated with simple common warts like what you see on your hands and your feet. Some of those types are associated with genital warts, and then some of those types are responsible for cancers that can be seen in both males and females. The most common type of cancer that is seen from HPV infection in females is cancer of the cervix, and the most common cancer in males that is associated with HPV infection are cancers of the tonsil, the back of the tongue, and the mouth.
Thanks for that answer. There is a vaccine for HPV. What should parents know about that vaccine?
I think it's really important for parents to know that this is not a particularly different vaccine. This is a vaccine that's made with the same kind of technology that other vaccines their kids have already had is made with. And it's actually a very important vaccination because it's one of the few vaccines that we provide that protects their children from future cancers. And I think it's a really exciting thing that we have a vaccine that can protect kids from an infection that can cause cancer.
Wow, that is great information for parents. Let's step backwards for a minute, though. What is the history of the vaccine?
So we have had a vaccination that protects against cancers coming from human papillomavirus since 2006. And so this vaccination has been around quite a long time, and we have lots and lots of experience with it with respect to how well tolerated it is and how effective it is. And so we are wanting to make sure that all of the listeners understand how important this vaccination is at protecting against an infection which is exceedingly common and which is the cause of cancers which can be very difficult to treat and can, for females, threaten their fertility, and for males, can result in rather disfiguring, difficult to treat cancers. So we're doing our very best as pediatricians to protect this generation from these preventable cancers with this highly effective vaccine.
What is your recommended age to receive this vaccine?
The human papillomavirus vaccination, or HPV vaccination, is approved for children down to 9 years of age. And it's actually a really good thing that we can give kids that age this vaccination because since this vaccine came out, we've discovered that younger kids actually respond better with their immune systems than older kids and teens and even young adults do. So it's great to be able to give this vaccine at a time when their immune systems are best tuned to take it.
Is it just as important for boys to receive it as girls?
Absolutely. The history of this vaccination is that it was initially authorized for girls because the initial studies were done just on girls with respect to risk for cervical cancer. But a few years after that, studies came out that showed how important it was at protecting boys against HPV-associated cancers. And we all know that boys don't have cervixes, but they do, unfortunately, get HPV infections that can lead to cancers later on in life. And the reason why it's really important for boys to get vaccinated is that the cancers that HPV causes in boys tend to cause cancers that appear in men in their 40s and 50s from infections they got in their teens and their 20s. And those are cancers of the tonsil, the back of the tongue, and the mouth. And so we're trying to protect our boy patients now from cancers that they may get decades later.
You know, this may be a clumsy analogy, and I'm certainly not a physician, so forgive me for this question, but we hear about shingles, and it's where the chickenpox virus is dormant, and then later in life you have shingles. Is that anyway what happens with HPV, where you get these earlier infections, but then later in life they cause problems?
Well, it is similar in that you're seeing a later effect of an infection that occurred, many years ago. But this is not a reactivation of the HPV infection. This is the effect of the HPV virus over a long period of time that changes the cells that it's infected that lead to cancers developing. And so it's not like chickenpox reactivated to create a different kind of infection. This is really just the late effects of an original infection that lead to cancer.
Well, thank you. That's a great distinction and a great answer. You mentioned tonsils and you mentioned mouth. What are some of the forms of cancer that could later develop, first in girls and then in boys, just to name a few, so our listeners grasp how serious this can be?
Sure. HPV infections can cause cancers in both genders of the genitals. So for females, we're talking about cancers of their external genitals, and for men, it can cause cancers of their external genitals. But in both genders, it can cause anal cancer, and that's something that unfortunately, oftentimes when it's discovered, is at a later stage, and it is quite difficult to treat. And so cancers of the genitals and of the anus, and then cervical cancer for females, and oral cancers in both genders, but primarily when you look at the data, that's mostly affecting men. So there are lots of cancers that can be protected and prevented by HPV vaccination.
So let me ask you this. Is there an age you reach where there's no need to get the HPV? In other words, is it one of those things where if someone's unsure whether they got the HPV earlier in life, but say they're age 40 or 50, should they consider getting the HPV?
This has to do with how much risk exists with HPV infection and how much time has passed since a person became a sexually active adult. And obviously, with more time and more experiences in that area, the more likely it is that they may have already become infected with certain types of HPV, but not all types. And so within the confines of the HPV vaccination indication, what the FDA says, what is the age range which you can get the vaccination, it's a good idea to get the vaccine because even if you've been infected with one type of HPV serotype, you may have not been infected with other types of HPV. And in this particular case, we're talking about 9 different types of HPV that are in the vaccine, some of which are associated with cancer, some of which are associated with genital warts. And so as long as the person is within the age range of being able to get the vaccination, then it's fine and it's a good idea to get the vaccination.
You know, it's interesting. And, I just learned something, and maybe the listeners didn't know. Within the vaccine, you said there were 9 different types of problems you could have that it could impact. That's amazing.
Yeah. So some of those types are closely associated with risk for cancer, and some of those types are more closely associated with risk for genital warts. And the latest age indication, just to get back to your question, was that is the age range that people can still get their vaccination for human papillomavirus or HPV is up to age 45.
Okay, thank you. That's really good information to know. And some people may be under a misconception, but if you get the HPV vaccine, that doesn't mean that it would prevent you from getting sexually transmitted infections, correct?
That is correct. The HPV vaccination does not protect you from other kinds of infections that you can get through sexual contact. But I think that you've raised an important point that needs to be clarified. Sometimes parents and other people who are thinking about the HPV vaccination look at HPV in the same context as other sexually transmitted infections like chlamydia and gonorrhea and syphilis, which require obvious sexual activity to transmit. HPV is much more easy to transmit. And so if you think about activities that are not actual intercourse or actual sexual acts, like, for example, making out, that kind of activity for teens, which is known to happen in teenage years, is perfectly sufficient to transmit HPV. So it's much more easy to transmit than these other infections that people are familiar with.
We're listening to Dr. Jason Terk, a pediatrician at Cook Children's. We're learning his thoughts on HPV and the HPV vaccination. A topic that, as Steve mentioned at the beginning of this interview, is one that you should discuss with your primary care physician or pediatrician about how you should proceed. What we're going to hear in the next segment when we come back is how prolific the cancers are from HPV. Even how cancers that we are treating as adults now, before the HPV awareness came into vogue, very well may be tied to HPV. More with Dr. Terk next on the Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is the Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing our conversation with Dr. Jason Terk, pediatrician at Cook Children's, about HPV and the HPV vaccine, a topic that you and your pediatrician or primary care physician should discuss about how you would incorporate this information into your family's medical decisions.
What are some of the common questions you hear from parents about the HPV vaccine?
A lot of parents are asking whether it's necessary for their children because they think about this as a vaccination for people who are sexually promiscuous, which is not true. I have to tell people, unfortunately, that this is such an easily transmitted virus that 80% of our children will become infected with the types of HPV that can cause cancer later on without this vaccination. So with something that is so easily transmitted, it makes sense to protect yourself. That's the first question I get. And then, unfortunately, we're living in an age where there is a tremendous amount of disinformation online. And even well-meaning parents who may not have preconceived biases toward vaccinations generally or HPV vaccination specifically may go online to try to seek out information, and they're going to encounter disinformation which is intended to deceive them and which will dissuade them from getting their children vaccinated, which is really a tragic thing when you think about the opportunity to protect someone from cancer. And so I oftentimes have to do a lot of debunking about disinformation that people have read about or heard about online. That's a pretty common conversation nowadays.
Where does HPV originate in our bodies? Where does it come from?
Well, we don't generate HPV within our bodies. It is a transmissible infection from person to person, and so it's not something that comes from us. It's a life form like any other infectious disease is a life form, a bacteria or a virus.
Okay, so it goes into our system, and then one thing we've all become very clear of the last several years is that, like with COVID, would attack the lungs or attack the throat. Does this attack a particular area, or is it that delayed cancer manifestation later on?
Well, human papillomavirus tends to affect what we call epithelial cells, and those are surface cells in our mucous membranes, and in the case of common warts, our epidermis or skin, and so that's the type of cells that HPV tends to infect, and those acute infections may be things that we can identify because we see a wart. That's a manifestation of acute HPV infection. But women, for example, can't see their cervixes, and so the only way they know that they may have an HPV infection that is causing problems is they get a pap smear. And that's what a pap smear is all about, is to look for abnormal cells that represent the effects of HPV infection. That's why cervical cancer screening came about, because the only way you could know you potentially had a problem was to do those tests.
So is HPV a sexually transmitted disease?
HPV can be transmitted sexually, but HPV is also much more easily transmitted than other sexually transmitted infections. And so activities that are intimate but fall short of actual sexual activity are perfectly sufficient to transmit HPV. You can even transmit HPV through open mouth kissing. So it is that easy to transmit. And so it's important that people understand that this is a risk that you cannot avoid by virtue of your own good choices, because we as human beings have contact with each other. We have intimate relations with each other that are not necessarily sexual activity, which are perfectly easily sufficiently easy to transmit the virus.
Now, those of us who were kids of the 50s and 60s, I don't remember this. Mono was big back in the day. Is this new? What's the history of it?
So the understanding that HPV, or human papillomavirus, was the causative agent for the majority of cervical cancers became understood in the 1980s. It is relative to people like maybe you and I who have gray in our beards that this was not a thing back in the day when we were kids, at least was not something that was generally understood. And as time has gone on, we've come to understand the role of this type of infection with human papillomavirus and its association with future risk for cancers.
Now, when you mention warts, one of the, again, back to the era that we came from, genital or oral herpes comes to mind. This is different, right?
Yes. Herpes is a completely different virus. It's not even in the same family of viruses as human papillomavirus. It certainly is another example of a virus which has different types. Certain types of herpes viruses can cause cold sores and sores on your hands. That's herpes simplex virus. Then there's also genital herpes, which is a different type of herpes virus. And there are other kinds of herpes viruses that you didn't even know were herpes viruses. For example, chickenpox is a type of herpes virus. And there are types of childhood infections that are not herpes simplex virus, which are also herpes viruses. And so viruses are an interesting and varied group of things that we deal with quite a lot in medicine.
So the understanding is that this was always there, kind of like Pluto, for example, that was discovered in 1930. It was always there. We found it. We had the technology then that developed to find it. Is that kind of what we're looking at here?
Yes, sir. That's the nature of our evolution in science and medicine. We come to understand that some cancers are associated with infections, and then we can drill down and see what those infections are. And ultimately, with this particular infection, we've been able to develop a vaccination that is highly effective at protecting us from infections with the viruses that can cause those kind of cancers.
Now, the thing that's concerning to me about this is, I guess, with a sexually transmitted disease, the time between the encounter and the manifestation is X, whatever it is, and then you get the resulting manifestation of that particular STD. Here, you're talking about cancer that could come decades later. Is that correct?
That is correct. That is absolutely correct.
So a big delayed effect of this thing that you could be exposed to, and now you're saying the age of 9, sure, kids 10, 11, 12 can tell us more than we ever knew about sex in our whole life, right? So we're talking about a much younger age group that could encounter it and it could not show up for them until their 40s or 50s.
That's correct. But keep in mind that the whole purpose of vaccination is to protect against an infection before there's any consideration of risk. And so you want to try to get that protection in as soon as possible when a child is able to receive that protection. Now, I look forward to a point in time when we're able to vaccinate against HPV infections at a much younger age. There's nothing conceivable about the type of vaccine that HPV vaccine is that wouldn't be appropriate for even younger children, not because we think they're at risk at that time, but because we want to get the protection in before there's any consideration of risk. This is not the first cancer prevention vaccination that we have had available. The hepatitis B vaccination is given to newborns, and we finished that series before a child is even a year of age. And we were protecting against hepatitis B infection, which can cause acute hepatitis and chronic hepatitis. But one of the late effects of hepatitis B infection is liver cancer. And so it really is the very first cancer prevention vaccine, and we've had that around for decades.
I'm so fascinated with this. Okay.
I can tell you're fascinated.
Well, you mentioned transmissibility, and here's the deal. You said kissing. We could take that a step further. Oral sex. We could take that a step further. Unprotected sex. Everybody's doing all of the above.
But here's the deal. If 80% of us are going to become infected with the type of infection, the means of transmission is irrelevant.
Wow. That's some heavy information from Dr. Jason Terk, a pediatrician at Cook Children's. Thank you so much for joining us with your thoughts. Steve?
We want to thank you for joining us for the human side of healthcare. And remember, tomorrow's Halloween. Please be safe and join us next Sunday on the human side of healthcare.